There's the need for better recognition of the diabetic foot. We need to acknowledge that it's associated with morbidity and mortality, and there is a disparity in terms of the outcome.
Let's be clear today that when we are assessing skin tone, we are not assessing ethnicity. That's two completely different things.
Consider the person as a whole and not just the hole in the person.
So what is the take home from Chris' presentation? Don't rely on redness. Welcome back, everyone. Thank you so much for getting back in the room on time. I think next year we're going to have an incentive for every break afterwards, because I've never seen people get back here to the room so quickly. So it definitely worked. We're going to move on to a session I've been looking forward to for some time. So we're going to be thinking about what does it look like to diagnose and refer foot care complications in diabetes in people who have darker skin tone. So I'm a pharmacist by profession. Most of the training for any skin disorder, skin condition that I've seen has been in light skin tone. So this is a huge step forward, and I'm so incredibly grateful to the co-authors, reviewers, the Royal Society for Podiatry, and Monlica for allowing us or supporting us to do this resource. I won't speak too long. I'm absolutely delighted to introduce Dr. Chris Manu to do the first presentation of this session. Chris is one of the most passionate, incredible speakers on this topic that I've heard. And I have heard many passionate speakers, some of whom we have following on from him today. But the first time I met Chris was a long time ago, I think about 6+ years ago, where he did a session on foot attack for foot care. And it stayed with me to this day, and I've been chasing him to do presentations ever since. So I'm absolutely delighted that he's managed to make it here today, and he's going to kick off with the first presentation. Can we have a round of applause for Chris?
Thank you. Thank you. Thank you so much. I know time is not on our side, so apologies if I rush through things. But also hope I won't put you off your lunch, nor the tea and biscuits that you've had. So I make no apologies for some of the pictures you're going to see, but I think it is important. And I'm also very, very pleased that at least this year we've been given the front stage as well, because diabetic foot disease seems to be the Cinderella story when we're talking about diabetes and its complications. And when it's in break session rooms, it's the room that no one goes. They go there and they rinse their face and they go and look at all the pumps, the gadgets, pregnancy, and all the other fancy stuff. But they walk into the diabetic foot session and off they go. So no excuses now. So what I had to start the scene by telling you about, maybe you might already know about the diabetes complication, the consequence of having a diabetic foot, the prevalence and outcomes, specifically in people with darker skin tones. And then in the second part, start making an indication about why the diagnosis can be slightly difficult. And then you have more sessions about maybe what the solutions might be. So I'll start by demonstrating to you that there is a problem. And I'm sure you are all here because you think that there's a problem. So if you look at globally from diabetes, again, these are data that we will all be aware of, that there's about 500 million people with diabetes, but 3 out of 4 of these people live in low-income or middle-income countries. And like I said, most often than not, when we talk about complications, the ones that takes precedence are cardiovascular disease, kidney disease, eye disease, pregnancy, and so on. And diabetic foot complications is usually bottom of the list. But if we look at the, again, data from IDF, nearly 1 in 2 of people living with diabetes in these developing countries are undiagnosed. And 1 in 22 have got diabetes. And this is only going up. If you look at the global data, Africa and sub-Saharan Africa is where that is expected to go up exponentially. And again, if you think about the fact that, I'll rush on to this, in terms of what the global burden of diabetic foot disease is going to be, in a patient's lifespan or their life with diabetes, about 1/3 of them would develop foot problem. So the diabetes is going up, and 1/3 of your cohort will develop foot disease. If you've got a catchment area, you will expect an incidence of around 4% will develop foot disease. And this is even higher in developing countries. And those that have established neuropathy, we're talking about nearly 8% will develop a foot ulcer in the year. So whether you are you're managing a foot diabetes service, a GP, just have that in your mind that 4 to 8% of your patients will develop a foot ulcer, irregardless of their ethnicity background. And then you can then think about the consequences of what these people who develop ulcer would be. Rushing through to some of the data available in the US, although yes, there's a health system there, and maybe lack of insurance or coverage or education, lack of education, they tend to claim that is the reason why people of racial, there's disparity. So people with Hispanic or non-whites definitely have poorer outcome. And this is often quoted as because of the insurance, because of their income. And the complications are much higher. But if we come home, excuse me, if I may say home, in England, here, there's the National Diabetes Foot Care NDFA, similar to the NDA or pregnancy audit that most of you will be aware of. It's been going on for about 10 years, and the database now have nearly more than 100,000 people presenting with foot ulcerations on that database. And anyone looking after someone with a foot ulcer ought to register people onto this database. And I'll give you some of the outcomes that are sitting on this database. This looks at their outcome from presenting to their first presentation to expert assessment. And this is just looking at within 6 months. So this is within 6 months of them presenting to a service or someone who claims to be expert at looking after diabetic foot. Those that have drawn by the wayside, that have not been referred, they're not even counted for. So within 6 months, there is an major amputation rate of nearly 3%. So 3 out of 100 will lose their leg within 6 months of being referred. And these are nearly 100,000 patients on this database. And diabetes is going up. And this is in the UK. So when we talk about disparities, this is just about those with diabetes. I'm not talking about people with black and ethnic minorities yet. In the audits, we classify people as being severe ulcer or less severe ulcer. And I won't bore you too much because maybe it's not your area of interest, but basically it's just a 6-point score, simple to do, to score the severity of the ulcer in terms of where it is, whether there is ischemia, neuropathy, infection, then the size of the wound and the depth. So there's just these 6 points, and you score 1 for each one of them. And if you score 3 and above, then you classify it as severe. And your chances of being alive and ulcer-free, if you've got a severe ulcer, is 34%. So the more severe your ulcer, the poorer the outcome. And again, this is within 12 weeks. Chances of being diseased, of dying, within 12 weeks is 4% if you got a severe ulcer. So we need to pick up those that have got a severe ulcer, and we need to do something about them because they are dying silently. Again, if you look at the whole database, and this is the people with less severe ulcers, and this is available online if you go to the NDFA website you have. So if you look at people with white or Caucasian compared to black, people of black origin in this database, you could see that, so this is the opposite. So these are those with the less severe. So on average, it's 48% of people of the black and ethnic minority having less severe. And so there's almost a 10% disparity difference in terms of the severity when people are of black and ethnic minority when they present with their foot ulceration. So not only are they presenting more severe, but they are also presenting late. This is looking at their self-referral. So again, people of black and ethnic minority are presenting later. So again, about close to a 10%, close to 10% or 8% difference in terms of presenting late, presenting more severe. And what is the consequences of it? I'm sure you see this picture subsequently presented in different forms. So if you present with a foot ulcer, your mortality is, just having a foot ulcer, is around 40% at 5 years. If you have an amputation or you lose one, you're going to around 50% mortality. If you have a major amputation, you're going to around 60% 5-year mortality. And this number is getting higher and higher. When you've got diabetes and when you are black and ethnic minority as well, it is higher. And we hear this quoted over and over again, it's worse than most cancers. The next part, perhaps I give you a bit more about why it might still be a problem. And I said I will leave the solutions for later, and then we all agree that we need to try and find solutions. So time and time again, I'll get asked, what is diabetic foot? And sometimes we think about just the foot ulcerations, but it's important to remember that anything structure that is in the foot can get damaged, be it the bones, the tendons, the ligaments, the skin, anything around the foot. So diabetic foot is not a rare herring that we need to be looking for as something that is rare. But basically anything can go wrong with the foot. And I think about it a bit more like the fire triangle, whereby we need three things to start a fire, which are, shout out, oxygen, heat, fuel. Some people have passed their fire, When you think about the diabetic foot, think about all those three things. So three things need to come together: neuropathy, vasculopathy, and immunopathy. Those are the three things that are going to make the diabetic foot worse. Neuropathy, they cannot feel their feet. Vasculopathy, their blood vessels get blocked. And then immunopathy is the infection. They are not able to mount an infection. So whenever you are assessing a diabetic foot, just like the fire, you need to think about looking for those three things. And those are what the textbooks teaches us to try and find out. So I'll go through those three things very, very quickly and swiftly. Starting with the blood flow, vasculopathy. We all get started off in our training, medical school or A-levels, whichever way. There's usually the 6 P's of ischemia. Ischemia, PAD, poor blood supply, same thing. That we taught to look for pain, pallor, pulseless, paresthesia, paralysis, and perishingly cold. And sometimes we taught to look for capillary refill. Straight away, you can think that people with diabetes, these symptoms will be much more diminished compared to someone without diabetes. Their foot will be painful when it's getting ischemic early. But if you've got neuropathy, that pain will come very much later. And then even if you try and do a capillary refill with someone with a very, very dark skin tone, it will not be as accurate, and most people will then ignore it. We talk about pallor, that yes, it's very, very easy to see pallor in people of light skin. But if someone has got a very, very dark skin, it's very difficult to diagnose that. Hence why these can be picked up very, very late. In general, in diabetes, we talked about, or diagnosing ischemia, we talk about people having rest pain. So when your foot is very, very ischemic, then when you are lying flat, the foot is painful, and you have to dangle it by the bed of the side of the bed to allow gravity for the blood to get to the feet. So that's rest pain. But when they've got neuropathy, that will come very, very late. We talk about sort of the blood supply. So you can think about Wembley being a place to play football. When there is a football match in Wembley, the M4, I think that's what goes to Wembley, I think. The motorway that goes to Wembley will be fine when there's no football match going on in Wembley. But when there's a football match, the motorway becomes crowded, and the motorway may not be large enough. Think about the foot the same way. When you've got no infection in the foot, no ulcer in the foot, you might have a degree of ischemia, and that might be adequate. But as soon as there's a tissue breakdown, you need more blood to get there, and then that's when relative ischemia can set in. Hence, the foot might look okay today, but 1 week time, infection sets in and necrosis sets in. And because of diabetes, high blood sugar, yes, the infection can become more rampant. And we talk about in people without diabetes, one of the cardinal signs is claudication. As they walk, they start to feel pain in their calves. And that's what we ask all people. Have you got any claudication? Even when people are doing their diabetes, have you got any claudication, any pain on walking? And what do you think the people with diabetes will say? No. Because you have to have blockage of the blood vessels in your thigh for you to have pain in your calves. But in people with diabetes, the problem is below the ankle. So they will not get claudication. By the time they start getting claudication, then the whole leg is completely blocked up. So all of these early signs are against our patients with diabetes. And when they've got a darker skin tone, again, it is much more difficult. The patients in the middle here, it is much easier to see the sunset changes of the forefoot. Whereas the one on your far right, if I had not shown you the other leg, you might think that, okay, that leg is just a little bit dark. So it's always important to compare it to what it talks about the skin tone. If I had covered that other leg, you wouldn't appreciate the degree of ischemia and infection in that leg. You might think I would just go a dark leg. And it's always important to look. I won't dwell on this much because you have more about that. Yeah, 5 minutes. I'll be done. And here, if you look at the foot from the base, again, you might not lose much sleep. But here's the foot from the top part of the foot. Oh, it's just a blister. You take the blister off, okay. Is that erythema? Is that ischemia? This patient had to go to theater, and that's how much tissue was lost. But we've put a skin flap on that, and it is doing well. Another quick one. From the bottom of the foot, benign, nothing to worry about. This is from the top part of the foot. Compare it to the other. Again, no one will lose sleep about that. But goes to theater, that's how much dead tissue is in that same foot. And it's lost nearly half of the foot. Well, we can put a vacuum dressing, we can do a skin graft, we can use the toe to cover it. But the severity can be very, very small. It's like that you've seen the tip of the iceberg, and these people are suffering. I'll rush through these for now. Infection-wise, again, the guidelines tells us look for erythema, and you classify infection from 1 to 4. So the level of degree of the redness clears the severity. And again, I'll rush through it, but I'm emphasizing on the erythema, which you might not always find in people with dark skin. It's rather hyperpigmentation. So again, take that with a pinch of salt. And I come back to neuropathy. This is a patient with a nail in his foot. Goodness knows how long that nail had been in the foot for. But because of the neuropathy, they are not going to feel it. And the top of the foot was just dark. So again, the three things, as you all said it with the fire, neuropathy, vasculopathy, and infection or immunopathy, do watch out for that in more detail. So in summarizing it all, I think the diabetic foot has got this triad, and we need to look harder, because there will be decreased inflammatory response, there will be decrease in systemic response, decreased erythema, and decreased pain as the warning signs. But if we catch it early, like this, we can still save the limbs, and we need to push for these people to be referred early. My 5 minutes is gone, but that is basically the summary. Globally, as I've said, there's an increase. There's the need for better recognition of the diabetic foot. We need to acknowledge that it's associated with morbidity and mortality, and there is a disparity in terms of the outcome or identifying the severity. But the key bit is for all of us to identify it early and refer them on. Thank you.
Can we have another round of applause for Chris, please? Next year we might give him even more time, because we have two fantastic speakers coming, but I just wanted to add, so what is the take home from Chris' presentation? Don't rely on redness. We saw there the post-surgical pictures. Shocking. You would not know that from the pictures. So thank you so much for illustrating that. Incredible presentation, and we're going to have to give you this whole session longer next time. While I load up, and I'm going to introduce Lakshmi in a second, we've also got a video. Chris Manu kindly came and did a presentation for us for a virtual event. You will find it online. I think it's got close to 45,000 views now, so it's very popular. We can direct you to that afterwards in a follow-up email. Next, another powerhouse in foot care. I'd like to, Lakshmi, you're going to blow them away again. Chris has done a great job, but Lakshmi, we've got some big hitters, basically. So Lakshmi is nurse consultant tissue viability at London North West University Healthcare NHS Trust. Done a huge amount of work in this area in care in people with dark skin tones in terms of tissue viability. And she's going to show us how to use the skin tone tool, and we're going to find out our own skin tone as well. So it's going to be very, very exciting. Lakshmi, please welcome her.
Good morning, everybody, and thank you so much for making it here today, because just by coming here, you've proved that you're really keen and determined to make a difference. And that's what we need. How do we empower each other to make a difference to our population? Because unless we educate ourselves, we can't give good health education outside. So thank you. But thank you, Bernadette and Diabetes Africa, for going out and about and really pull up all strings to get the diabetic foot care, to us. We have reached global, because I've had people reaching out to me from New Zealand, Australia, South Africa, America, Nigeria, to say how useful that handbook has been for them. So thank you. I really, really thank you for that. So today my session, I know we're short of time. That's because of you, Bernadette. You've treated them. You've treated them with the diabetic foot handbook. But hopefully, we are around after the session. If you have any question, please do reach out. Or if you don't want to ask today, email me as well. So this is a fact, and I'm not going to go through too much literature, but Dr. Chris Manu has very kindly shows us the numbers, have shown us the impact it's having, and unless we take action now, we can't undo these numbers. But while it's a major contributing factor, if we do try to capture it early, we can make a difference. And my role as a clinician, as a nurse first of all, is what do I do to prevent these things from happening before they get to Dr. Chris Manu? Because if we can, as a nurse, as a clinician, podiatrist, practice nurse, healthcare professional overall, can target it early, we can prevent the severity that Dr. Chris Manu very kindly showed us. So the challenges remain, and trust me, we've started our first publication in 2021 and we're still rolling all the drums because there's still lots of work to do about skin tone. Where to check, how to check, and what do we check? So very often I speak to relatives because they are the one looking after the loved ones, and they say, I don't know how to check. The only way I found out is I found blood in his socks. That's why we're here. Why do we wait for blood in their socks? So as a nurse, right, I've been community as well. So how many times we go in people's house and walking barefoot is their culture? But we can't change it. But that it is my duty of care to tell these people it's absolutely fine. We're not here to change your culture. Do check your feet every day. Use a mirror. Get your loved ones to do it, because this is why we can prevent the early sign of damage from happening. So it's very simple. Where to check, how to check, and what do we check? So we did a survey globally again with Wounds UK, and we sent a survey across everybody. We had loads of healthcare professionals ranging from vascular to student nurses, healthcare professional, plastics, podiatrists, nurses, but it went global, as I said. So we had the whole of EUs, because we target European Wound Management Association, we target the Asian countries, we also targeted UK as a whole and the UAE. So we had loads. But what does strike you in this slide? Look at the last part. 21% who reported they feel uncomfortable documenting or asking about skin tone is because 73% of them felt that they were worried about offending the patient, or they were worried about getting it politically incorrect or being called a racist. Let's be clear today that when we are assessing skin tone, we are not assessing ethnicity. That's two completely different things. And when you take time to explain to the patient that you tell them what you see, that's where we build relationship with our patient. They know, this nurse knows what she's talking about. I'm not a tick box exercise. We're not treating everybody equal, but equitable. And there's two different things, being equal and being equitable. So as a result, all these documents are free to download. If you go on the Wounds UK website or Wounds International, there are hints and tips in there for us clinicians. The second one was a global consensus that we did, and we actually consented patients to find out what do they think about us assessing skin tone. Are we getting it right? And one lady said to me, how would you like me calling your skin mayonnaise? Took me back. It's like, I hate it when I go to my nurse and she doesn't know what my skin look like, and she said, my skin is cocoa color. Another one said my skin is caramel. Another one said it's hazelnut. So this document helps us to use the right words, and please do not associate skin tone with food derivatives. It's offensive. So as clinicians, we've got to know how we're addressing skin tone, and that's the first step in getting the confidence of your patient in your care plan together. Following on these, there's more documents that has been published, and to help all of us here in this room as clinicians, putting it into practice, because we've broken it. Pressure ulcers, wound care, diabetic foot, moisture lesion, everything. And it's for the wider, from a non-registered to a qualified nurse. Everybody can use it. And at the moment, I am doing quite a lot of teaching with doctors, because I'm sure you know, if they see dark skin coming in with a patient that has been scratching, straight away they'll be prescribing antibiotics, right? So this is where us as clinicians, it's our role to help us deliver best practice, because these people may have eczema or just may have dark skin that's very itchy. But because it's darker doesn't mean they've got cellulitis, and antimicrobial resistance remain our job to prevent it. And here come the big one. If you haven't downloaded it, yes, please do, because it's one very, very, very useful tool that will walk through the journey with you, irrespective of the wound care you're looking. So that QR code, I'm hoping Greg will tell me yes, but it should still be working. This is the skin tone tool that you all have in your hand, and this is what I've used in practice. And the reason we use it, because we wanted our clinicians to be less reliable on how do I call it? What color is this? We want you to be evidence-based. And the skin tone tool here tells you, if my patient has got the left foot 4A and the right foot a 5A, we've got a problem. But same way, at the same time that you're checking it, your patient can also visually see it as that's how I check. And this is why education starts, because then the patient knows this is my normal skin tone. If it's darker than this one, I've got to seek help now. And while we're seeking help early, we're preventing further damage. So in my trust, we've implemented it and we've made it business as usual. So everybody from ED right to the ward, to the discharge team, they must use that to assess patient skin tone, because there's no reason why we should create harm in the patient when we have evidence-based tool to prevent it. So diabetic foot ulcer complication, as Dr. Chris Manu has already talked about it, the changes in color, it may be spot difficultly because we are so taught. 18 years ago, when I started my journey as a TVN, I was told, you see red, you react to it. But how wrong was that? Because we don't see red every patient. But now this is where I took a step back and I'm educating my new workforce to say, move away from redness. The over-reliance of redness is what has led our population with dark skin tone get higher degree of harm, and it was too late. So we've already caused them harm. And that's the reason why, again, things like that, if we captured it early, because look at the discoloration on the foot. If we had seen that fungal infection early enough, could we have prevented it? Yes, because the patient would have sought help early. So that's one of the reasons. It's really important to know what's your complication, tell it to them, tell them what they are, tell them where to look and what to look for, because they might not feel the injuries or the pressure until the wounds is, hello, I'm here. So again, this has already been covered by my colleague, Dr. Chris Manu, so I'm not going to go on it, but I would love to show you some pictures. And again, apologies if that. This is important, you see the real patient, and just to say all the photos, I have full consent for teaching and publication, because the patient are willing to share their experience so that we prevent it from happening. So diabetic foot, as you know, it can just start from somebody doing a bit of gardening because they got neuropathy, they didn't know what to do. And this is one of the lady who actually, I remember very, very well, was looking after her husband. She was the main carer, so she never had time for herself. And when she had something, she just brushed it off and carried on. But until she found the big wound, she freaked out. And when she was admitted to hospital with us, you can imagine she never wanted to be admitted, because who is going to look after my husband? I am the main carer. And that was her main thing again. She never wanted treatment. She wanted to self-discharge, but it was how we work with her, empowered her to make sure that she get the right support so she can support her family members. So this is John. And again, if you remember the symptoms before, if John had known about the early signs of foot damage due to his skin tone, we could have prevented that. You can imagine what that led to. That would be one of the pictures Dr. Chris Manu just showed us. Look at the extent of damage it would have happened. And all these are real patients. This is Maria. Maria had numbness 3 months ago, but dismissed it until she got this. But unfortunately, that led to a severe hallux amputation. This is how deep the damage was. But you can see it's like, oh no, it's nothing. It's still very superficial. But these are things that we need. If I had given Maria the skin tone tool early, she would have reached out earlier and this wouldn't have happened. She wouldn't have lost her right hallux. So please do use your skin tone effectively. Document your findings, because this is the best way of using the right language, the right terminology, without, feeling, am I doing the right thing? This will increase your confidence and your confidence of using it. Any training, any teaching you're doing, please show the difference in light skin tone as well as dark skin tone. In the Diabetes Foot Care Handbook, we've made it a must show you what does fungal infection look like in a light skin tone, what does it look like in a dark skin tone. Do the same when you're teaching your student, your workforce, your colleagues, do exactly the same. Show them, because if you look at digital imagery, when we started the first publication, there was nothing on dark skin tone. It's now that we're starting to collect pictures because we want everybody to be aware. Look at redness in the variety of skin tone. We can easily miss the last one, right? So that's why it's important. So assessment, use your senses, touch and feel. If the patient can, look at the differences in color. And remember, your skin tone is important. Look out for these signs because the skin might feel slight, spongy, shiny, but move away from redness. Don't do the mistake that I did 18 years ago. It's important. And be aware of culture. What can you do? All your risk assessment, be skin tone aware. Adopt a holistic approach, but yet integrated. Remember, as a patient, there should be no care about me without me. So get your patient with you on that journey to address inequity. What it means for you, again, I'm so sorry we are going through, but hopefully Bernadette will summarize the whole thing at the end. Listen, listen, listen to your patient. Nurse, doctor, my leg has been very itchy. I have sleepless night. Look at what's happening. Ask them, have you noticed any changes in the skin color? Don't look at dark skin as a challenge in clinical practice, and remember, it's completely different to ethnicity. So after this session today, go out and be confident. You're not being offensive. If anything, you're being holistic. So it's important you do that. Skin tone in practice, hopefully you can do that. I am not going to go through it, but I will really want, if you have a chance during the break, identify each other's skin tone so you know how to correctly see different skin tone. That's what we do. It's important to know it. Thank you. Sorry, Bernadette.
Luxmi, thank you so much. You were short for time, but high on impact. Really, thank you so much. One takeaway that I want to share with everyone since my conversations with Luxmi, and it hit me like a hammer, actually. Imagine going into patient notes and it says, the heart rate was faster, or the temperature was hotter. We so are used to using quantitative methods for describing signs and symptoms. Why is it for skin tone we are so far behind? So next time you're looking at someone's skin tone and you're thinking of using caramel or cocoa or any other variation of a brown food item, think about why am I describing this differently from blood pressure, temperature, or anything else that we use. We have a tool now which can support. Thank you so much. And moving swiftly on, Debbie, you've got the last session, but I know you're going to be equally as impactful. Debbie Sharman is a consultant podiatrist, the lead for podiatry, co-chair of the Foot in Diabetes UK. I know that is a very short summary of what all the multitude of things that you actually do, but I'm delighted to have you here to be speaking about how we can embed dark skin tone considerations into best clinical practice. So can we have a round of applause for Debbie, please?
Thank you. While we're just changing the slides over, it's a real honour to be here today, and I'm really quite humbled to share the stage with such eminent other speakers. And you'll see I've tried to match the colour here. I've got the pink rather than the orange, but I've done my best. So thank you very much for having me. And my task today was really to pull together what Dr. Chris Manu has said and Luxmi. And so what do we do with that information, and how can we embed these considerations into our clinical practice each day? I'm not going to linger on this slide because Chris has eloquently highlighted the problems in terms of mortality, how foot disease compares to the cancer rates and the prevalence. But what we do know is that in a person's lifetime of having diabetes, between a quarter and a third will develop a foot ulcer. And complications of the feet in diabetes actually take up 1% of the entire NHS budget. So it is a huge problem. It was a privilege being part of the group to develop the handbook, and I've sort of picked out some of the nuggets from that to share with you today, and I hope very much you'll be able to take that handbook away and really use it and have it help your clinical practice. So we've talked a lot about redness, and what we need to do is look beyond the standard signs of complications, redness and pain that we tend to associate with foot complications for the reasons my colleagues have already told you about. We may not pick up on those early signs and symptoms, so we need to be more aware of the subtleties, those slight changes, and make sure that people with diabetes are aware of what to look for. So some of the history taking considerations, it is really important that we consider that cultural humility, and this is discussed more within the handbook. Being mindful of the diversity of people's backgrounds, and that may, what are their lived experiences as well. Is there a history of or a fear of racism and discrimination that might lead to a distrust of healthcare systems and providers that might hinder that communication? So that's something we need to be mindful of and try and address. Social determinants of health, particularly socioeconomic status, education, the physical environment, how people live their lives. Understanding these factors can provide important context to help improve health. Family history is really important. There may be a family history of diabetes and complications, but also, for example, sickle cell disorders, which are going to be more prevalent in dark-skinned populations. Mental health and communication styles are really important that we consider this. And what is the person's preference? Is it for direct versus indirect? And what is the cultural norm about discussing personal or sensitive information? And what are the expectations in terms of communication styles? So I'm bringing Janet with me today, and Janet was referred to my clinic down in Bournemouth in February of this year. She'd recently arrived in England to help look after her young children. Luxmy mentioned itching, and Janet's problem started as itching between the toes, and she was given an antibiotic cream for that. And she thinks that the wound on the dorsum of her right foot probably started from scratching. She went to the emergency department not long after she'd arrived in January. She was reviewed there. There was no redness in her foot, was actually what was written on her ED discharge summary. Antibiotics not indicated, discharge back to GP. And that was the extent of the summary from the emergency department. So we've fed back in relation to that. So I saw Janet for the first time in February, probably about a month after she presented to ED, and it was actually a healthcare assistant at her GP practice who raised the alarm and thought, this isn't right, and referred her into the foot clinic where we first saw her. Her feet were swollen, the left foot more so than the right. They were both painful. She had no pulses in her feet. No redness had been recorded in her feet, so she hadn't had any antibiotics since her arrival in the UK. So on this first visit in the clinic, we decided there were clinical signs and symptoms of infection. So she was commenced on high-dose antibiotics. We arranged for x-rays and ultrasound arterial Doppler scans of her arteries. So here we've got a critically ischemic foot with gangrene in a person with a light skin tone. And you can see quite clearly there the redness within the foot and that gradient distally, that sort of sunset ruber that we often see in the ischemic foot and the associated gangrene. So imagine that same foot in somebody with a dark skin tone, and it can be hard enough to actually sort of pick out the gangrene, let alone the signs of ischemia. And the diagram on the right-hand side is one that our vascular scientists locally provide us so that we don't have to scroll through the actual Doppler scans and pretend we know what we're looking for. This, for simpletons like myself, gives us a much better visual representation of the blood flow down to the foot. And I think you'd probably agree with me that the scan on the right here might be one that you would expect to see with that foot on the left. But actually that was Janet's scan. And you can see she's got blockages in her thighs. And as Chris said, you know, by the time she's getting sort of pain, the whole lot's blocked off, which it pretty much is here. She's got the distal disease. You can see in the three main arteries leading down to the foot, they're pretty much blocked up, and major blockages in her arteries. So obviously, the first time we saw her in clinic, we were actually able to get that scan done the same day, but didn't get the results the same day. And just going back to the difference between pale skin tones and dark skin tones, again, on the image on the left-hand side of your screen there, you get a much better visual image. You can see the cyanosis in the tips of the toes, which are not apparent in a dark skin tone. So we have to sort of play the role of detective. Because the symptoms of ischemia and infection, or a combination of the two, are going to be far less obvious. So 2 days after we saw Janet for the first time in clinic, her son phoned us, concerned that her left foot and leg had become more painful and swollen. We were then able to see her scan results, so I spoke to our on-call vascular surgeon. Janet was accepted for admission and her family brought her into hospital. She underwent angioplasty of the common iliac, external iliac and common femoral arteries, and she was discharged from hospital 7 days later with antibiotics. And you can see here the fourth toe was starting to develop necrosis there. And this is a combination of, this is 2 days. Remember Dr. Manu said at the start how quickly things can change. This is a combination of ischemia, infection, absolutely devastating in the diabetic foot. So when we're assessing the feet, we've already talked about using all the senses, not just relying on that redness. On the picture, this is Janet's foot again, and I don't think I've got a, maybe not a, here you may be able to just make out a darker skin tone there, and that's the redness, the erythema, that we would more easily spot in a lighter skin tone. So we need to make sure that we've got good lighting when we're assessing, examine the skin and document those findings as Lakshmi said. The best practice statement, lots of nuggets in there. I'll pass on that as Lakshmi's already mentioned that, and a really good tool to help practice. The Act Now cards, these are also available to download to give people, and the acronym Act Now stands for accident, change, temperature, new pain, oozing or wound, and any of those should prompt a prompt referral onwards, and these are all freely available for you to download and issue to patients. So really just to summarise, careful inspection, listen to the patient and their story. Have they noticed a change in symptoms? And as we've discovered, people with dark skin tones will frequently notice changes late, missing those early warning signs. We do have a really unmet need for education to help early identification, both for people with diabetes and also healthcare professionals, and it's really heartwarming to see so many of you here this morning and still awake while we're talking about feet. Hopefully those gory photographs have played some part in that. Consider the person as a whole and not just the hole in the person. That's really important. We need to avoid those delays in accessing care. As Lakshmi said, dark skin should not be seen as a challenge, but we need to work to reduce those health inequalities and inequities. So this is my call to you to take away from today, is to go away and please make an impact. Learn what to do during your consultations to improve foot care for people living with diabetes, and empowering them to identify problems early and seek treatment. And thank you very much.
Can we have another quick round of applause for all three speakers, please? One incredible takeaway from your presentation, Debbie, was that the person with diabetic foot-related complications, and in the note, the discharge note wasn't read, sent home with antibiotics. How often must that be happening? And thank you so much, Debbie, Chris and Lakshmi, for all you're doing to make sure that that's happening less and less over time, and hopefully it won't happen in the future. Thank you so much for your passion. I really appreciate you coming here to speak today, so thank you very much. Thank you, everyone. I hope that you've learned a lot. I think if you're like me, the pictures initially are a bit jarring, and then you kind of get used to it and the information can come in. But like you said, we shouldn't be afraid of feet, and we should be proactive. So thank you so much.